Good morning, everyone. So today I'm going to talk about identifying the optimum peak. So while working in ICU, we are seeing the many cases of ARDS. And the one challenge that we all are facing always is to how to set the optimum peak. So today I'm going to talk about it, and I will I will try to give the correct answer to this question. So the first thing is why the optimum PEEP is necessary, because it helps in improving the lung protection, minimizing the risk of ventilator associated lung injury, and it also helps in oxygenation and ventilation. So when we are giving some PEEP to the patient, it is always necessary to assess the individual response to that PEEP. And it is necessary that our lung should recruit to the PEEP that we are providing to the patient. Now, what is the lung recruitability? So it is defined as the proportion of the lung tissue in which aeration is restored at the increased airway pressure. So when we are setting PEEP according to the lung recruitability, we should know about the two basic concepts, that is strain and stress. So the strain is the change in the lung size that we are when we are giving the pressure to the lung, and the stress refers to the changes in the lung tissue that are producing in the lung in response to the applied pressure. So whenever we are applying some PEEP to the lung, then the lungs are inflated above their functional residual capacity, and then it is subjected to the additional static stress. So in this scenario, if the patient is low recruiter, then our applied PEEP will cause more harm to the lung instead of improving oxygenation and ventilation. So we should be very vigilant in applying PEEP. So how to optimize? Now the next question is, what is this optimum PEEP and how to set this, and what are the methods of optimizing PEEP? So the first is empirical PEEP setting. So it is entirely based on our clinical experience. So first we'll set the PEEP and then we'll adjust it according to the oxygenation and the lung mechanics. The next is we can find out the recruitment to the inflation ratio. So it is performed by single breath decremental PEEP by 10 centimeter of water. Now what is the meaning of it? So first we need to find, first we'll increase the PEEP to the 15, and then we'll calculate the compliance of our recruited lung. And then we'll reduce the lung PEEP by 10. That means we'll make it then that means we'll fix it to the 5. And then again we'll calculate the compliance at this low PEEP. So by calculating ratio of it, we'll come to know who are the high recruiters and who are the low recruiters at the bedside. Now the next method is gradual increase or decrease PEEP, and then simultaneously we need to assess the physiological response to the PEEP. That means if we are setting higher PEEP and the patient is giving appropriate response, if the patient's hemodynamics is improved, if patient's oxygenation is improved, then that means that PEEP is helping in this patient, and we can go with the high PEEP. But if the patient is deteriorating, then gradually we can reduce the PEEP according to the patient's oxygenation, hemodynamics, and mechanics. Now the next method is by using the esophageal manometer. So for calculating PEEP by this method, we require the esophageal catheter, which we are placing on the lower third of the esophagus. Now, what is the concept behind it? Because this pressure in the lower third of the esophagus is the direct reflection of the pleural pressure. So we can estimate this transpulmonary pressure, and if we adjust our PEEP according to the transpulmonary pressure, then we can prevent the lung collapse, we can increase the recruitability, and also we can minimize the lung stress. And the next method is electrical impedance tomography. It is a non-invasive technique. So how we are doing that? We are applying the electrodes from the second intercostal space to the fourth intercostal space of the patient. So the one electrode will be the reference electrode, which will be the sending current to the other electrodes. It will create the impedance and it will display the images on the screen. So by means if we'll get the one image on the screen, and then we'll adjust our ventilatory settings, and then we'll compare this images before its ventilatory setting and the after the ventilatory setting, and we can judge whether our lung image is improved or not. And then we can find out the appropriate ventilatory settings according to the improvement in the images of the lung. The next are the we can take help of the images like imaging techniques like CT scan, lung ultrasound. So by using the CT, we can assess the amount of the gasless tissue under high pressure and the low pressure. By using lung ultrasound also same, we can set the PEEP according to the re-rating tissue at the regional level. So my take on optimizing the PEEP is while setting the PEEP, we should always assess the individual response, and we should carefully assess the patient's hemodynamics, oxygenation level, as well as we should keep the eye on the lung mechanics. And by balancing all things, we can set the optimum PEEP to the patient. Thank you. Thanks a lot.